Hello and welcome to SciLux, the podcast for people who love science or for those ones who don't yet know that they do. And in today's episode, our guest is Dr. Marina Kvaskoff, who works in the Epidemiology of Gynecological Health team of the Center for Research in Epidemiology and Population Health in Villejuif in France. Marina focuses on research into endometriosis and women's health in general, and I have to warn you that today there will be no pub quiz question because, as Marina said, endometriosis is a quiz on its own. Thank you so much, Marina, for coming today.
Thank you. It's a pleasure.
I tend to start the podcast with a little bit of admitting my lack of knowledge or my problems. And I have to seriously say here that endometriosis is something I learned about maybe 3 years ago. And I think this does still tend to be a problem when it comes to the knowledge of people about the illness. So first of all, tell us what it is and why we don't know more about it. I mean, I know you're not responsible for this, but still.
So endometriosis is a disease in which the cells that are lining the womb, the uterine cavity, are found outside of the uterus. In this disease, those implants, those lesions, are responsive to hormones of the menstrual cycle, and they will bleed as if they were inside the uterus. And so this leads to lots of pain, inflammation, scarring, sometimes adhesions between organs and those lesions. And it can be really a debilitating disease because it can cause lots of pelvic pain symptoms. So pain during menstruation, dysmenorrhea, pain during sexual intercourse, dyspareunia, pain during defecation, dyschezia, during urination, dysuria, and also acyclic pain, so pain that is uncorrelated to the menstrual cycle. It can also lead to abdominal pain and also functional digestive symptoms and also chronic fatigue. It's also a cause of infertility. So 30 to 40% of women with endometriosis may be infertile. It's a disease that has lots of impact on women's quality of life and in all domains of their lives. So, social life, love life, family planning, education, career, mental health.
So, first of all, I think one of the problems, there are loads of issues here, as you said, because it's definitely not discussed enough. We're not aware and all that. But I think there is an issue about the whole menstrual cycle and the awareness of what is happening. Because to be honest, I know that a lot of listeners are men who are listening. And I wonder if we were to ask our listeners right now, what do you know about the menstrual cycle, what they would say? Because it's one of those things that, well, if you're lucky enough, at school, you learn a little bit, but it's often that age when the boys don't necessarily want to hear about all this. And then maybe they get interested, maybe the parents tell them something, but it's not so often the case. And one of the things I, for example, would like to admit is that I hope, so far, I don't think I have endometriosis, but I have a lot of pain in my menstrual cycle. And I'm pretty sure that a lot of people never knew anything about it because we women who menstruate learned that, well, this is normal. Our life continues, right? We take a painkiller or we don't take a painkiller, and then it continues. It's just something that for us becomes such a natural part of the whole deal. And then we learn not to discuss it too much, right? You don't go to your employer and say, sorry, well, today I can't, right? Maybe still with PE classes at certain moments, there are moments, I also know that some girls actually abuse this, but that's a different story about this. But in general, that's it, right? And here what we're saying is that the pain is such that it really influences the quality of life to a way greater extent. Mm-hmm. But the problem is also that sometimes we tend to confuse the pain we have thinking, well, this is still normal because nobody told us what is normal in this case, right? So we don't get diagnosed. Am I right in this?
Yes. So, the menstrual cycle can lead to some level of pain during menstruation, during the periods. But basically, if you take a painkiller and you're fine, and you don't have any more trouble, then, that can be considered as pretty normal, right? But if you take painkillers and the pain is still here and it interferes with your everyday life, then that's where you need to be aware of it and consult a gynecologist, because it's not normal to have such pain that you need to stay in bed, for example, or that you can't go to school, or that you can't go to work. If it interferes so much in your life, then this is not normal pain.
So this is the sign. If the menstrual cycle is such that painkillers don't help, it's too much, that's the moment when you definitely should go and check. But then, as far as my numbers say, it takes 8 years to diagnose. Is it because people don't go to the doctor, or what's going on there?
So in the literature, there's a 7 to 12 year mean delay for diagnosis of endometriosis. There are two parts of this delay. So one part is on the woman, who will take some time between symptom onset and the first consultation. And there's also the time between the first consultation and the actual diagnosis. The reason for the first delay could be that, women may think, oh, this is normal, or it happened in my family, or they may speak to their surroundings, and surroundings may say, oh, that's not much, or I had the same, and, I'm your mom, aunt, or big sister, and say, well, it's just like that in family. So this will take some delay. And then you also have, lots of women, actually, we see it in the data as well, who will go and see doctors, and doctors will say, well, we don't see anything on imaging, so this must be in your head. Pain in women has been really trivialized in history. Unfortunately, we have a bit of this heritage. So we have a large cohort of women, 10,000 women, and we performed a study to study diagnostic delay. So there was a 10-year mean diagnostic delay. And although we were not able to measure the two parts of the delay, we saw that the delay went from 0 to 42 years. And for 42 years, we thought, this is just outliers in the data. It's not real data. But we checked the comments, and actually many women said, well, it actually took me 42 years to get diagnosed because no doctor wanted to believe me that I had pain and that I had those symptoms. And so, it's really been a big problem. Thankfully, nowadays, there's been so much awareness raising. There are two countries where there are some national strategies as well, so in Australia and in France. And so now we talk about the disease a lot more, and healthcare professionals are being more and more trained. So hopefully this is going to change in the future.
Because as you're saying, it's not only a question of it takes time to actually go and seek help, because first you assume it's normal, let's say, but also the fact that the professionals are not trained.
Not always. So you really need to be an expert in the disease to be able to recognize it. So there are several types of lesions. And the most obvious type of lesion is the endometrial cyst, so the endometriotic cyst. We call it chocolate cyst because it's a cyst that is filled with blood. Because it's a bit big, you can see it on ultrasound, and this is okay not to be an expert to see that. But there are some other forms of disease, such as deep endometriotic nodules and also superficial endometriosis. And so to be able to see this, you need an expert eye. So for radiologists, it's important to go and see a radiologist that is experienced and expert in the disease. And also for surgeons, because they will know exactly how to identify the disease in the pelvis and also to treat it, although it's not always treated by surgery.
Exactly. So as you move to treatment, let's talk a little bit about that. But we understand there is pain.
There is not always pain. Sometimes asymptomatic cases. So sometimes women feel no pain at all. And this is completely uncorrelated to the severity, to the extent of the disease in the pelvis. One woman can have stage 4 endometriosis and she can have no pain at all. And so often women will discover that they had endometriosis when they go for an infertility workup, and they're told that they have endometriosis and that's the reason for the infertility. But most women will feel pain, and there are different levels of pain. Some women feel milder pain and some women feel very deep, debilitating pain.
And when you say stages, what are the characteristics of those stages?
So there is a classification system called staging. It's from the American Society for Reproductive Medicine. They produce staging, which is surgical staging. It goes from 1, which is mild or light, to stage 4, which is severe. And it's actually a calculation based on several criteria. So you need to calculate a score, and the score is divided in 4. But basically, stages 1 to 2 are usually endometriosis that's confined to the pelvic cavity, and that's mostly superficial endometriosis. And once you start to go to stages 3 and 4, you get to endometriomas, so those endometriotic cysts, and you can get into the deep endometriosis nodules as well, which is deep endometriosis that's infiltrating the pelvis and the peritoneum. So this staging is not completely satisfactory because there is no correlation between staging and symptoms, and staging does not predict treatment response. So you can have, stage 1 disease and have extremely debilitating pain. And it can also be that, usual treatments won't work easily. And you can have stage 4 disease and have absolutely no pain. It's a classification system because we need to define what we see for the disease, but it's difficult to use it because we have no classification system that's really correlated with the impact of the disease and treatment response.
Exactly, because I know you also do research in cancer, and when you started talking about stages, I started thinking of cancer, right? And that's completely a different type of. If you tell me which stage it is, then I already understand how much it is developed and also what the treatments are. Whereas here, it's different, right?
Yes, definitely, because for cancer there is a progression. So you know that stage 1 is going to progress to stage 2, 3, 4. It will go from localized to metastasized if not treated. But for endometriosis, there's no sequence. You can have stage 3 disease and we haven't seen anything before, and we don't actually understand the natural history of the disease very much for now.
And then one more thing I think we did not mention. So let's say there are 8 more women listening to the podcast. That makes us 10. So one of the listeners and us probably has endometriosis, right? We're saying 1 in 10. Am I right with the statistic?
Yes, we say that 1 in 10 women are affected in their reproductive years. So that's between 15 and 49 years old. But it's really a gross estimation. We don't actually know exactly how many women are affected. So if you take different samples in the literature and you look at different studies, you will have very different numbers. And it goes from very small numbers in electronic health records or among women in particular samples. For example, women seeking tubal ligation. So that will be 1 to 4% of disease in those instances. And this is clearly underestimated. And if you look at samples in whom there is symptomatic disease, so women hospitalized for pelvic pain, dysmenorrhea, or women with infertility, you will have much bigger numbers and can go from 5% to 50% in infertile women, or even 100% among adolescents with severe pelvic pain. This is clearly overestimated. So basically, researchers and healthcare professionals have thought, okay, if we look at the prevalence of symptoms and of infertility in the general population, it will be about 10%. But we don't really know if it's less or if it's more. Often, gynecologists who are expert in endometriosis will tell you, well, it's definitely more because they see lots of patients, so they can have this impression, but we don't actually know. And that's why we need really good data to measure endometriosis prevalence in different samples and different populations, different geographic regions.
And we go to an extremely important topic when it comes to women health, which is data, right? I mean, there are somewhere here some books on that. There was Caroline Perez, I think, wrote Invisible Women about the data that is collected on women's health in general. And that's a different topic. There's a lot that we still have to do. But coming back to a situation where I am under serious pain, let's say, it's clearly not only related to menstrual cycle. I have to seek help. I go to a GP, I go to a gynecologist. Where do I go? I don't know, maybe in France, if you're saying that it's one of the countries that has a proper national strategy, it's easier to find help because you know where to go.
Yeah. So theoretically, you could go to primary care doctors. So you can go to your GP. You can go to your gynecologist. You don't need to go to an expert center on endometriosis. But in France, as you said, there's the National Strategy Against Endometriosis that was launched in 2022. And since then, we have care pathways that have been organized geographically. So in each geographic region, there is a defined care pathway. So if you have symptoms, you will connect to the website and see where you have primary care doctors who are expert in the disease. And then they will refer you, depending on your case, they will tell you, well, you can keep seeing me, I can manage your disease, or you need to go to this specialist, this gynecologist specialist, and then specialists will discuss the cases and see if they need to go to an expert center or not. So this is really good because, it's not always easy to access expert medical care in endometriosis. And so this system, hopefully, because it's just getting started, but hopefully this will really change the landscape and help women with endometriosis know where to go and being cared for early on in the disease.
And in other countries, I guess it means that if you go try to get a diagnosis and the expert tells you there's nothing, maybe you should get another expert, right? I guess that's, or maybe some association that can help you out with information and places where you can go.
Definitely. Patient societies have been really great advocates for the disease, and they've really helped patients and also raise awareness of the disease in society and among politics. And they can help you find doctors. So if you're in a country where there is no specific management organized for endometriosis, you can go to patient societies and they will know how to advise you. It's happened a lot in the past that some women have had some imaging results where a non-expert would say, you have absolutely nothing. So it's all in your head and everything. But then they go to a specialist who say, you've got lesions here, there, and we're going to treat you. That's why it's really important to be trained. Otherwise, this can increase the delay in diagnosis. So it's really important to go to the experts.
Of course. And now let's say I've been lucky, although I don't know whether you're lucky when you have endometriosis, but lucky in the sense I'm diagnosed, right? And then what about the treatment? So what can we do about endometriosis?
There are several strategies for treatment. So most of the time, this includes medication, and medications can include painkillers or most of the time hormonal treatments. And the aim for this treatment is to suppress menstruation. So often you will be prescribed a pill, so contraceptive pill, which will stop the periods. And so it will stop the inflammation, and often it can get better. If it's not an oral contraceptive, it can be a progesterone treatment with progestogens in it. And the same, it will suppress menstruation, and it can help with quality of life. And sometimes you can be eligible for surgery. Not all the time. So what I must say here is that before, several years ago, the way we diagnosed endometriosis was through laparoscopy. And laparoscopy is basically a mini-invasive surgery where you don't do a laparotomy, where you cut everything and open. You just pass. You have small holes for the instruments and one hole for the camera. And it's really a small impact in terms of cutting and opening. And once upon a time, we used to only diagnose endometriosis through this type of surgery. So you actually needed to go inside the belly and to see if there were some lesions. Nowadays, we can diagnose endometriosis through imaging, so through transvaginal ultrasound and also through MRI, the magnetic resonance imaging. At the time where we only diagnosed endometriosis through laparoscopy, that's also the only way we treated the disease. It was always through surgery. But nowadays, we are less and less invasive. So we are less and less performing surgery to treat the disease, because the case is not always eligible for surgery, because you can have different types of pain. So if you have neuropathic pain, for example, so you have involvement of the nerves, or you have central sensitization, which is basically, the central nervous system that has been overstimulated and that now interprets stimuli that are not usually painful as pain. And so when you have this type of pain, usually it's not recommended to perform surgery because it can actually aggravate pain symptoms. Nowadays, and especially in Europe, and we've had recommendations from the ESHRE, the European Society for Human Reproduction and Embryology, in 2022, that released new guidelines that said that actually you have only certain cases that you need to perform surgery on. And so sometimes you can be eligible for surgery. And when you are not, it's going to be mostly a medical treatment with also some adjustments in lifestyle. So you can be offered therapeutic education. So this is really good because it really helps patients learn about what they can do in their everyday life to ease the symptoms. And so that can go from, physical activity, adapted physical activity, or nutrition, or physiotherapy, for example. This needs to be really tailored to women's symptoms because not one endometriosis patient is the same and not one disease is the same. So it really needs to be specific to the particular case. And so this can really help. In some instances, when there is neuropathic pain or sensual sensitization, there's also some other types of treatments that can be given, such as antidepressants, for example, or anti-epileptic treatments sometimes. So when there is this type of pain reluctant to treatment, often it involves seeing a pain specialist, a pain doctor, who will help manage that pain.
It's just, obviously we have those 40, 50 minutes and there's so much to discuss. We could only focus on what to do, right? And the nutrition part and the physical activity and all that. This was more on the patient side. So now we've introduced people to what to do when you have maybe you suppose you have endometriosis. What do you do when you get diagnosed and all that? But now I want to go to your research side. So how is it to do research in that field?
How it is to do research in that field?
To do research in that field, because it's one of those fields that I think, I don't know, looking from the funding side, is it easy to get funding for endometriosis research?
No, it's not really easy to get funding for women's health in general, although this may be changing. So in France, we're very lucky because we have the Foundation for Research on Endometriosis, which is the only foundation in Europe that is raising funds for endometriosis research specifically. And also, we are very lucky with the National Strategy Against Endometriosis because the research arm of the strategy is to fund a specific program on women's health and couples' health. And so it's funding research for endometriosis and infertility. So no, it's not easy to get funding for endometriosis research, but nowadays, everything that happens is really, so with the foundation, with the national strategy, it really helps to get new people, so new researchers from completely different fields. So with an expertise in cancer, an expertise in biomechanics, for example, physics, to be interested in the disease. And so this is extremely positive because to crack the enigma of this disease, we need absolutely all of the different competencies and skills to help us understand endometriosis. This has been very positive. In France, we've seen a lot more researchers from really different fields coming to this research. And so the way we do this research, well, it really depends on the field. But basically, it's good to have an expert with you when you do this research because it's really specific. And in the research that I do in epidemiology, epidemiology is the science that studies the distribution of diseases in populations and that also seeks to understand the risk factors and progression factors for the disease. And so what we do in my lab is that we are looking at the descriptive epidemiology, so looking at how to refine the numbers for prevalence, so that 1 in 10 number, and also for incidence, so to know how many people are affected every year and is this growing or declining. We are also working on risk factors for diseases in order to discover the causes because we don't really know much about the causes of endometriosis, which are largely unknown. And we are also working on disease heterogeneity to understand the different clinical forms and phenotypes of the disease in order to link this to treatment response and to the natural history. We're also working on progression factors and consequences of the disease, so both in terms of life impacts and in terms of the risk of other chronic diseases later on. The way we do that, we have several tools. So we are working with population cohorts and patient cohorts. So population cohorts are basically groups of people like you and me who volunteer to participate in research at some point in time. The participants will reply to questionnaires about their health, about their exposures, and they will be followed up over time. So maybe we follow them up every year or so, and we continuously ask them about those questions and sometimes some different questions. And that way we can follow when some people will develop the disease, and we will know who gets disease and who don't get it. And so when you don't have the disease, you are 0. When you get the disease at some point in the follow-up, you become 1. And we do statistical modeling to model how you go from 0 to 1, the factors that explain that statistically. And to do this, we are looking at some specific exposures. So, for example, environmental exposures, let's say air pollution, for example. We're looking at, we ask questions about where people lived in their life, and we link this to air pollution databases to know exactly, the particular matter, or the types of substances that we're exposed to. And then we adjust the models for known risk factor of endometriosis and potential confounders that may confound the associations. And so doing this, we will find whether or not there is an association between the exposure and endometriosis. And that's how you perform observational research for risk factors for endometriosis. And then when we work with patient cohorts, we are following up patients over time. And in France, we are working on the Compare endometriosis cohorts. The Compare is for community of patients for research. I launched the Compare endometriosis arm of Compare, and we have been following up 10,000 endometriosis patients over time. And we are looking at the factors that may explain the evolution of disease in terms of pain symptoms or other types of disease characteristics. And also, we use this data in order to produce information about the lived experiences of the patients, because we need to basically bring the voices of the patients to the world. You have lots of anecdotes about, people with endometriosis who will say, well, this has been my experience, etc. And here with this study and with this design, the real strength is in the numbers. So we are following up those, thousands of women, and we can ask questions, and then we can publish the results and say, well, this is what we find, and this is the lived experiences of the patients.
And I cannot emphasize enough the importance of participating in all the possible studies like this, right? Whenever I have specialists in the field of health, I always make this appeal. The listeners already know, please, if you have a chance, if you get letters from the government or you just get contacted any other way by researchers, participate in those, because only by the numbers, as you said, we can get any kind of meaningful data.
Definitely. And it has actually led to a new field or a new tool, which is participatory research. And in this participatory research, you basically work with the patients. And so what's interesting about this approach, for example, we work with a scientific committee where we have patients, we have researchers and clinicians of different specialties, and we work together to build the protocols of the research. Then patients have a say also in the way we formulate the questions in the questionnaires, and they can say, well, I don't really understand this, or this doesn't really apply to patient situations. And so this helps us refine the data collection and also actually sometimes the aim of the research, because the research priorities aren't necessarily the same between researchers, clinicians, and patients. And at the end of the day, it is for patients that we're doing this. So we might as well ask them, do you think that this is addressing your need, or is it something that's not really interesting at all? And, we're always surprised by how much more relevant it makes the research. So this is really good, and they can also help with popularizing also the findings. So it's really a really enriching experience. If you have any French-speaking listeners who have endometriosis or adenomyosis, we're working on both diseases, you can participate on compare.aphp.fr. compare.php.fr. And so you can participate and reply to questionnaires online. We're actually working with participants in the whole world. The only thing is that they need to be adults, so above 18 years old, and they need to be French speaking or understand French.
So they don't have to be living in France?
No.
Great. So we will share the link also in the show notes, because of course, whenever we're discussing something, either this, one of the studies or cohorts or whatever, there's always a link in the show notes so listeners can go click, and hopefully you will get the numbers up.
There's something I would like to mention again about research. It's about standardization of research tools to collect data, because, in case we have listeners who are researchers and would like to start to work on endometriosis or who are curious about it. So there is the WES, so the World Endometriosis Society. It's the leading society in endometriosis research worldwide, and it organizes congresses every couple of years. And they have, with the World Endometriosis Research Foundation, they have created standards, operations, and procedures for data collection in order for researchers to be able to work on similar data so that we can then combine data internationally and make more meaningful research where we're going to be able to compare data across countries. So in case you are looking to work on endometriosis, look at WES, W-E-S, look at WERF Effect, that's the Endometriosis Phenome and Biobanking Harmonization Project. And also WES has a mentoring program. So if you are completely new to endometriosis research and you would like a mentor to help you getting there, you can connect and you can register for this mentoring program, and you will be accompanied by a senior researcher or clinician to help you get started.
Yeah, that's a great appeal. Thank you for mentioning that as well. And again, we will share all the links too, in case you didn't manage to note it down. It's great you mentioned the Congress, because it's one of the things I want to do in this season of SciLux, is to kind of try to visit all these conferences that researchers go to and to understand. So let's say I'm at that Congress or any other conference for specialists who study endometriosis. What are the discussions about? Like, what is the, I don't know, is it about the methods in your case of collecting the data or designing the scientific experiments, or where is the core of your discussions, or maybe the disagreement, if you want?
There are discussions about everything really related to endometriosis. It's such a complex disease, and we still haven't understood all of it. There's actually so much to discover. So there will be discussions about methods, obviously, to, in every congress, but also about the causes of endometriosis, or, the way we picture the disease. Does it have any infectious origin? Because there has been a paper that was published on one type of bacteria, so Fusobacterium, which is very common, and that raises thoughts about, well, could this be one of the origins of endometriosis? So there's also discussion about pain, for example. So pain mechanisms are extremely complex. And at some point, we thought we understood pain well, but recently there has been a change in paradigm with the definition of another type of pain, for example. So lots of discussion about the microbiome also recently, and whether it could be implied in endometriosis. And so we are always and constantly progressing, and it's extremely stimulating because, you are always updating and revisiting what you think about the disease. And your research is going to help other researchers and clinicians progress in their research, and vice versa. So there's constantly an interaction and a discussion about where we're going, how can we discover more about the disease, how can we treat the disease, can we find some non-hormonal treatments for endometriosis, what can we do also to understand the heterogeneity of the disease, how can we, better treatment response, and lots and lots of things. And it's really interesting. I love congresses on endometriosis because it's always so stimulating, and you just want to make progress.
Of course. And that's also what I was thinking, is because you also do research in cancer, right? Here you can pick so many different subjects to look into, whereas cancer research is definitely a way more developed field. It's a completely different world, isn't it?
Yes, it is. And so for cancer, there has been lots and lots of funding because it's a disease associated with mortality. So we can really see the difference because now we've progressed a lot. So cancer used to be treated as one disease entity. So for example, breast cancer, we used to treat all breast cancers the same. And then several years ago, maybe decades ago, we discovered that there were different types of breast cancer. So we will treat some breast cancer cases with hormonal therapy. We will treat others with immunotherapy maybe, or we will treat others by some other means. We discovered personalized medicine also. So if you have some hormonal receptors in the tumor, or if you have some mutations in the tumor, you will give a different treatment. And this has dramatically changed the way we treat the disease. And it's also really improved patient care and also survival rates. Endometriosis is not a disease associated with mortality, not directly, but it's extremely impactful in terms of morbidity, and it's extremely frequent. That's why we need to put more funding in research on women's health, because when you have more funding, you will find more things. You will make much more discoveries. And so we need to invest in women's health. For that reason, it's really important. Investing in women's health is also associated with increasing the global economy. Yeah, so for endometriosis, it's the same. We are, 30 years back, if I can say, compared to cancer, because right now we call endometriosis some things that may be different diseases. We don't know. And we treat the disease as a single entity. We just notice some differences. We know that the disease is extremely heterogeneous. So in terms of different forms, so histopathological forms, but also in terms of color sometimes. The lesions can be bluish, red, white, black, brown. It's very varied. You can have also different appearances of lesions. You have different symptoms, different locations, because we haven't talked about that yet, but basically endometriosis is mostly localized in the peritoneal cavity, in the pelvis, and you'll have endometriosis sometimes on the ovaries, sometimes on this membrane that covers the internal organs, the peritoneum. But it can also be in other places. So, for example, it can be on the bowel, it can be on the bladder, it can be elsewhere in the body. It can even be in the heart or in the diaphragm, for example, or other places. Every organ has had a description of endometriosis lesions being present. So there's no one organ where endometriosis has not been described. Right now, we don't understand this heterogeneity. And this is where we need to put the effort in, is to understand the different forms in order to provide better treatment response. And so if we understand the different clinical forms, we'll be able to do some personalized medicine for endometriosis, and we will definitely improve health outcomes for patients and quality of life. And
Listeners, let us jump a little bit back, because you mentioned we did not really talk about how heterogeneous it is, but also I don't think we've discussed the risk factors. So let's do this right now.
So we don't know very much about risk factors for endometriosis. So the causes of endometriosis are largely unknown. We have different leads. So we know that endometriosis is a hormonal dependent disease. We also know that there are some genetic factors involved. And in fact, twin studies have shown that 50% of cases are of genetic origin and 50% of environmental origin. And of genetic origin does not mean that there is necessarily endometriosis running in the family, but that genetic factors are involved. So that covers both cases. And we also know that there is an aberrant immune response in endometriosis. So maybe some immunologic factors implied and some inflammation as well. And there's more and more data towards an involvement of endocrine disruptors, so endocrine disrupting chemicals. But when you look at the data, only very few factors have been associated with endometriosis, and we see different factors with different periods of life. For example, in the perinatal, so around birth period, we have a low birth weight that is associated with an increased risk of endometriosis. We have observed also that women who have their periods earlier in life, so for example, before 12 years of age, will have more tendency to develop endometriosis, those with shorter menstrual cycles as well. And we think that this is because, an earlier age at puberty and also shorter menstrual cycles, basically you have more opportunity to have periods. And so you have more opportunity to have implants and to develop the disease. And there's also another observation, which is a low body mass index that's also associated with disease. Although we have observed this, we have actually very little clue, especially in terms of modifiable risk factors. That's what we need to know in order to develop prevention for the disease. So we need to know what to advise women basically to decrease their risk of endometriosis. So that's why we are performing research in order to decipher the causes of endometriosis, because if we do, especially modifiable risk factors, we'll be able to inform the population and say, well, this is what you should avoid, or inform politics and to say, well, we really need to do something about endocrine disruptors because this is really impacting the risk of female disease. And so something we haven't talked about also is the pathogenesis of endometriosis. And I think it's important to touch base on that because we don't know the exact pathogenesis of endometriosis. So Sampson in 1927 proposed that there was a retrograde menstruation, so that, a part of the endometrial cells that are present in the womb, so those that will be shed with menstruation, they actually reflux into the tubes, and, some modified endometrium will be in the pelvic cavity. So this phenomenon actually happens in 90% of women, but usually the immunological system is capable of cleaning those fragments of endometrium. But in endometriosis, about 10% of women actually will get some implants that are staying there in the pelvic cavity and growing and bleeding every month. And that's what we don't really know why this happens. So this is one theory. That's the retrograde menstruation theory. But there are some other theories. So for example, the embryologic theory, which is, so there are two sides of it. So either that when we don't really know if the fetus is going to be a male or female yet, you will have some remnants. It's the theory of embryologic rests. So embryologic remnants that will continue to develop and that may cause endometriosis lesions. And it's actually the theory that explains that there is actually some endometriosis in men. It's extremely uncommon. In the literature, maybe 15 cases were observed internationally, but it can happen. And also some autopsies in fetuses have found that some fetuses had already some endometriosis lesions as well. And so the embryologic theory also proposes that embryologic cells that will later go on to become the peritoneum, that they transform under the influence of some factors, whether it be genetic or environmental, and later that will give rise to endometriosis lesions. So that's the two main theories. So retrograde menstruation is one, and embryologic transformation is another one. We believe that the first one is the most common, but it doesn't explain all cases. And none of the theories that are currently put forward to explain the origin of endometriosis explains all of the cases that we observe. But this is important to know because that's why also we suppress menstruation with the treatments. Because for those women who have endometriosis that is caused by retrograde menstruation, stopping the menstruation, stopping the periods is actually going to make it better because it will stop the reflux. Something I must say, though, is that I'm a scientist and I'm not a medical doctor. So I'm telling you, to the best of my knowledge, things, but this can't replace medical advice from an actual gynecologist that is expert in the disease.
Very important disclaimer, absolutely. And once again, going back, look for experts, right? Because again, you might be in France, but also somewhere else. And maybe the second opinion is not a bad idea. If you feel, of course, I'm not trying to appeal right now to question the experts, absolutely don't. But, there are moments when you actually, as a patient, you should have more agency and try somewhere else, because just might be an expert that is not trained in the field and does not notice the lesions, as we were saying, or whatever else. Okay, because we went back to some of the things we did not discuss, I also realized that we did not talk about the long-term consequences of endometriosis. So what are they? Okay, I understand you are under pain. What else? Can it lead to other diseases? What do we know?
Yes, so what we observe as well is that endometriosis is linked to other chronic diseases. This could be because there are some common risk factors, and that could be just a correlation, or that could be because endometriosis leads to a high risk of developing some diseases. If we take cancer, for example, it's the disease that's been the most studied in relation to endometriosis. Data don't show an increased risk of cancer in general. It does show a doubling risk in ovarian cancer, but there is something we need to discuss when we discuss that, because ovarian cancer is a very rare tumor. It's only 1% of women who will go on to develop ovarian cancer in their lifetime. And a double in risk among women with endometriosis is actually, putting this number up to 2.5%. So 2.5%, is also a number. What if you are in the 2.5%? I understand that. But we can really reassure women with endometriosis because 97.5% of them will not develop ovarian cancer. And it's really important to keep in mind that the numbers are extremely close to the numbers in the general population. So it's virtually almost no difference. And so this does not mean that you should be under more scrutiny for cancer risk if you don't have any other risk factors for cancer. So for example, genetic mutations or, family history or other risk factors. You don't need to go under specific surveillance for ovarian cancer risk, for example. So this is very reassuring. And also the types of ovarian cancers that are associated with endometriosis are associated with lower mortality or better survival. So it's not those most aggressive types of ovarian cancer. We also found a very modest association with breast cancer, so only a 4% increased risk. So this is compared to the double risk for ovarian cancer. And for thyroid cancer, there was a 39% increased risk. But so here again, it's not a major additional risk. It's really close to the risk in the general population. So no stress with cancer risk. Several studies have looked at the association between endometriosis and some autoimmune diseases. So, for example, systemic lupus erythematosus, also Sjögren's syndrome, rheumatoid arthritis, but also celiac disease, multiple sclerosis, and inflammatory bowel disease. So that's Crohn's disease and ulcerative colitis. It goes with the aberrant immunologic response in endometriosis, but what is interesting is that we don't yet know the direction of this association. It could be that because there is endometriosis, the immunological system, the immune system, doesn't know how to get rid of all of those lesions. So it's hyperstimulated, and it will lead to a high risk of autoimmune diseases. Or maybe there was some autoimmune disorder or different response in the beginning, and this led to endometriosis because it was not, the system was not able to clean the endometrial implants. So right now there's lots of research on this, and it's really important research to perform. And so then there has been some recently some data on some cardiovascular diseases, cerebrovascular disease and ischemic heart disease. So each time it's 20 to 35% increased risk. We know, for example, that some female conditions that are non-malignant are associated with a high risk of cardiovascular disease. And so we need to perform research on endometriosis as well in order to know whether there is a high risk, and if so, for which type of endometriosis patients. So in all of this data that we're examining, it's really important that we continue. So for now, it's giving us some clues about some potential common etiology, so some common origin maybe, but it could also be helping us to better monitor longer-term health risks. And so endometriosis has been associated as well with asthma, allergies, atopic diseases. It's been associated with infertility because it's one of the major causes of infertility. And, when you look at the literature, it's currently under study for, the association between endometriosis and many other diseases, so long COVID, for example, or, some other conditions. But so for now, there's no specific concern to have. We're just performing the research. For cancer, there's absolutely no concern to be having because it's so close to the general population's risk. It's very low. So if research confirms an association with cardiovascular diseases, then it might mean that women with endometriosis should be monitored more closely for cardiovascular health. And for autoimmune conditions, we are researching also, what to do with this data and what it could mean for management. But here again, I would like to remind people that I'm not a medical doctor, and so I can't, tell you all about what it means for healthcare management.
Yes, absolutely. That you have to find yourself with a specialist, or also looking at all the associations and their information. They have quite a lot of different things already online, but remember, of course, online does not work like a specialist in the field.
No. For the consequences of endometriosis, we know that endometriosis has a significant life impacts on several areas of life, so such as education or career, social life, family planning, personal social relationships, but also mental health and more generally quality of life. And so it's been shown actually that all of these different impacts in women's life can actually lead to an impact on life trajectories of patients. It can represent a loss of opportunity at different points in life that are really crucial.
The last thing I wanted to ask you is actually about, again, more meta analysis of doing research, in the sense that some of our listeners are people who either are thinking to become researchers or maybe are researchers and are thinking of moving. And I recently had a great chance to talk to a researcher who actually is doing science both in Denmark and in the Netherlands. So he was comparing a little bit. So now I can ask you, how is it to do research in France? Because you've also moved places. So I guess you have a comparison. We said that for endometriosis, actually, it's a good place to be, right? But in general, is there anything special about doing research in France?
So I've done research in Australia and in the US as well. So the major difference I see is investment in research from the government. I think we have a lot less in France. So it's different because you have several public institutions. So it's basically public, whereas in those countries where I've been, I think it's mostly private. Universities are private, although they have some subventions from the government. So yeah, we don't have much money, basically. I would say we can do research, but I think this is something that is really global, is that you need to apply for grants all the time, and it's for one project. So it makes it difficult sometimes because you are working with a team. You are relying on some people who have the knowledge, who know exactly what to do, who are really efficient, but you can only pay them for a year, maybe. And then when the funding terminates, you can't have these people anymore in your team. So it doesn't make it really efficient to work by project. In France, I think it changed in the past 30 years because it used to be more, the government used to give more money, money for each team. And I think that having that security would be best, because then you would be able to function with people and have, if you have some positions of people who are with you in your team, that would be great.
Okay, good. Whew, that was a long walk through the world that I really don't feel we discussed enough of. But at the same time, I hope that our listeners got the feeling, especially if you need to search for help, where to go, what it really means to have endometriosis. Hopefully more people will be aware again, and more people will participate in all the different important studies that scientists are doing in our health, so that then we get more data and we know more, and so on and so forth. I will not talk about the funding because that's a different story. Hopefully with all the different projects like Choose Europe, we will have a lot of funding given to European researchers. I mean, I have to be a bit of a positive in that. Also funding for science communication, I wouldn't mind that too, by the way, just plugging it in somewhere there. And what remains is to thank you very much, Marina, for today, for telling us a little bit about you. And remember, you can contact Marina and ask her more questions if you're interested. We will share all the important information in the show notes. Thank you so much.
Thank you.
And this is it for today. Don't forget to subscribe, to follow us, to check what we're writing on all the social media. And remember, you can also support us financially on Patreon. We will share all the links in the show notes. And when you support us, you can actually suggest guests and have a chat with us. There is a special channel for that. Thank you so much. This was Silex, and my name is Hanna Siemaszko.